Dear students, today's topic is laboratory diagnosis of tuberculosis. Laboratory diagnosis of tuberculosis. The objectives of today's class: basic concepts which are involved in diagnosis of tuberculosis, various tests which are available, and how to choose the various options in the availability of this diagnostic test for the tuberculosis. To begin with, why they are called as mycobacteria? Because in liquid cultures they form pellicle-like thing, so resembling fungi, and this happens because of the presence of cord factor. They are attached end to end, and it resembles fungi. Therefore, they are called as mycobacteria. The first mycobacteria were discovered by Hansen 1874. So Mycobacterium leprae was discovered prior. Then tubercle bacillus was discovered by Robert Koch in 1884, and about 100 species of mycobacteria are there. Out of that Mycobacterium tuberculosis and Mycobacterium leprae, they are well known. And there are also mycobacteria other than tuberculosis. They are called as saprophytic mycobacteria, and these are been found in the human lesions, and it is very important to differentiate it. So now it is the mycobacteria, the tuberculosis, Mycobacterium tuberculosis complex is proposed, in which Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium microti, Mycobacterium caneti, Mycobacterium capre, etc. The species are there. Because of the genetic studies, it has been categorized under Mycobacterium tuberculosis complex. So clinical features: most common presentation is pulmonary tuberculosis, in which evening rise of temperature, loss of weight, loss of appetite, cough. These are the features, common features. Then afterwards, if it is ignored or not, the healthcare system is not approached, then it will lead to hemoptysis. Then extrapulmonary tuberculosis, the signs and symptoms are depending upon the organ involved. The tuberculosis can involve any organ of the body. It may be uterine tuberculosis, it may be the skin tuberculosis. So almost all the organs can be involved. So it causes the protein clinical manifestations. So our focus on the today's topic is laboratory diagnosis of tuberculosis. So demonstration of the tubercle bacilli in the clinical specimens by microscopy and cultural techniques. The first we will see the sample collection, direct microscopic examination methods, concentration methods of the specimens, especially concentration method of sputum, then culture, what are the various culture methods available, sensitivity testing, Mycobacterium tuberculosis shows drug resistance, therefore sensitivity testing becomes very important aspect nowadays, animal inoculation, and molecular methods. The first is the sample collection. The early morning sputum sample is preferred because the mycobacteria are concentrated in the sputum in the morning. The tuberculous activity occurs in the overnight period, so chances of a positive finding is increased when the morning sample is collected. In the old guidelines, 3 successive days early morning sample was given, but the patient compliance was not there. Therefore, there was a modification by RNTCP, or now it is called as National Tuberculosis Elimination Program, where one spot sample, whenever the patient approaches the healthcare system, one spot sample is collected, and then we have to give the container and ask the patient to give the early morning sample on the next day. And if sputum is not produced, you can go for laryngeal swab, or bronchial washings can be taken, or bronchialveolar lavage is also taken. Usually, this pediatric population, the patients will have the tendency to swallow the sputum, in which gastric lavage can also be taken for examination of the sample. So depending upon the site involved, if there is a tuberculous meningitis, CSF sample is collected. If the pleural fluid, if there is a pleural effusion, pleural fluid is taken. Urine sample in case of urinary tuberculosis or renal tuberculosis, or if there is a aspirates from bones and joints, if the infection is involved in those parts. So this is the sputum container. It should be properly labeled with patient name, form, number, unique number, and date of collection. During collection, the patient should go into the open air, and then inhale the air, and uh, then uh, then he should uh, cough it. cuff properly so that the deep secretions present in the respiratory tract should come in the sample. And it should not be saliva. So the proper instruction should be given to the patient so that the proper sample is obtained. The quality of specimen is very important for the appropriate diagnosis of tuberculosis. Then direct microscopic examination. All of you know ZN staining is the most important age-old method. 125 years back, since 125 years we are using ZN staining, but sensitivity is less. About 10,000 bacilli should be there per ml, should be there to give the sputum sample as a positive results, and it should be stained with the ZN staining, and at least 300 fields should be examined. If there is a negative result, at least 300 fields should be examined to declare it as a negative smear. And what is the importance of grading of the smear? Grading of the smear gives the severity of infection, how much is the load of infection, infectiousness of the patient, and also the grading of the smear is helpful for prognosis. We have to do the patients on treatment, we have to go for the repeated examination of sputum sample. If the grading is decreasing, that means the patient is responding to the treatment. So grading is given by NTP, erstwhile that RNTCP. If more than 10 bacilli per oil immersion field, it is a 3 plus. 1 to 10 bacilli per oil immersion field, that is 2 plus. 10 to 99 acid fast bacilli per 100 oil immersion field, 1 plus. 1 to 9 bacilli in 100 fields, scanty. And no FB seen after say screening all the 300 fields, it is declared as a negative. Then there is another method of microscopic, that is called as fluorescent or LED microscope, LED microscopy, in which the specimens smears are prepared and it's stained with auramine rhodomine stain, and it is seen under the LED microscope, and you can see the auramine rhodomine stains the bacilli, and entire background will be dark or greenish color background, and you can see the acid fast bacilli. And further, it should be confirmed by Jordan staining method, because sometimes there may be non-specific fluorescence and it may be misinterpreted as a false positive. So therefore, this fluorescent microscopy should always be confirmed by Jordan staining method. What are the advantages? We can rapidly screen and pick up those which are positive, but it should be further confirmed by Jordan staining method. Then concentration method, sometimes the clinical suspicion will be high, but our smear positivity will be less. In that case, if the clinician is strongly suspecting, we have to go for Petros method. Then there is another method known as NALC method, L16 method. So Petros method is most commonly used method. In this, sputum is mixed with equal concentration of 4% NaOH, and we have to shake it. The alkali will liquefy liquefy the sputum sample, and it becomes clear. So this procedure should be done for 20 to 30 minutes so that it will become a clear liquid. The tenaciousness or that thickness of the sputum sample will not be there. Then we have to go for centrifugation at 3000 revolution per minute for 30 minutes. The supernatant is discarded and deposit is taken. For further examination, it should be neutralized with 8% hydrochloric acid, and this is used for the inoculation of culture media like LG medium, and it can also be used for the smear examination. So what are the advantages? In this, there will be digestion, decontamination. The commensal organisms are there in the sputum sample, so that gets decontaminated, that gets removed, and simultaneously concentration of the sputum method. So two methods are there: Petros method, which is most commonly and popular method, and second one is a NALC method. Then automated microscopic technology by TBDX is developed, where the slides are stacked inside this portion of the machine, and the slides are stained and these are mounted on the stage. And we can say this is the knob which is helpful for changing the field, which can be displayed on the screen, computer screen. So we can interpret it. So that automated method technology is developed by TBDX. Then go for the culture. Culture is very sensitive method. 10 bacilli per ml can detect. Inoculated media are incubated at 37 degrees Celsius temperature. Then cultures are examined weekly up to 12 weeks. Usually growth obtains at 2 to 8 weeks. Then we have to incubate for 12 weeks. Don't declare negative. Before that, we have to incubate it for about 12 weeks. So you can see the growth of Mycobacterium tuberculosis. Here you can see the colonies of Mycobacterium tuberculosis on LG Melanstein junction medium. The colonies are described as rough, buff, and tough colonies. These colonies are further identified by a biochemical reaction. Mycobacterium tuberculosis gives niacin test and nitrate reduction test. Both tests are positive for Mycobacterium tuberculosis, but niacin and nitrate reduction tests are negative by Mycobacterium bovis. Then there is a radiometric method for detection of the growth that is called as BACTEC 460 TB. So it can detect uh, the growth in 9 to 14 days. So it is a radiometric method in which the carbon which is labeled is with the radioactive carbon C14 is used, and the metabolite which is there, palmitic acid is used with that carbon in Middlebrook 7H12 medium. And during the growth of organism, the radioactive carbon is liberated, which will stimulate the sensor and which will give the results. So the turnaround time is decreased within 9 to 14 days. The growth is detected and we can give the report. So advantage is that early detection, but here we are using the radioactive substance, so always there will be the hazard of disposal of the radioactive material. Then next method is MGIT, Mycobacteria Growth Indicator to 960. So this is the instrument in which the turnaround time is again 9 to 14 days and no radioactive material is used. So this is the fluorometric method. So what is the principle of this method? In this, the growth of organism, there will be, because of the metabolic activity of the organism, the oxygen is absorbed. So lack of oxygen in the medium will cause the fluorescence in the medium, the fluorogenic substance, and which is detected by the sensors. So presence of oxygen will quench the fluorescence. So once the organisms grow in the medium, because of lack of oxygen, so the quenching effect will be decreased and leading to the fluorescence, and that fluorescence is detected by the sensor which is there in the machine and which will give early result. So there is a no radioactivity hazard because it is a fluorometric method. So it is not a radiometric method. Another method is a BACT alert 3D, alert 3D, which is a calorimetric method. The metabolic activity of the organism inside the medium will lead to the change in the pH of the medium, and the color substance, there will be change in the color substance of the indicator which is present at the base of the medium, and which will stimulate the sensors and give the result if it is positive. So again, it is a safer because there is a no radioactive hazard. You can see the machine where the bottles are loaded with the patient specimen, and in case if there is a growth, it is displayed in which slot there is a growth. We have to take out the bottle and then go for the further identification and further antimicrobial susceptibility testing. So that is the MB-BACT alert 3D system. Then come to the molecular methods, PCR and LCR. These are the molecular methods. And among the PCR-based method, Gene Expert MTB, RIF, that has become most popular. It is being supplied by the state government and we are having this test. So it is a closed system, closed in the two sense, like we have to purchase the consumables from the same company in which such consumables, the cartridge is available. All the reactions will occur in that cartridge. So it is a PCR based system. We have to just charge. There is a small opening on the machine on that cartridge. We have to charge the patient specimen, and then all the things, all the DNA extraction, amplification, everything will occur inside this cartridge, and there is no question of opening it. So it is a safer for the technicians. So all the processing is a closed system. It is a closed system in the sense that we are purchasing from the same company. Also, it is a closed physically because there is a no exposure to the laboratory technician. And about 2 hours, it will give the graph where the amplification of those particular target gene sequences will occur. It also gives a rifampicin resistance also. So for drug resistance also it is very helpful. The gene which is being amplified, that is RPOB gene which is helpful for detection of rifampicin resistance. So this has become more popular because it is very safe method. Then similar TrueNet, Indian company TrueNet is there. It is supplied by Molbio, which is a Goa-based company. So this is the equipment, and these are the consumables. You can see the consumable contain chip. Again, we have to go for decontamination, and we have to charge this cartridge and load in the machine. It will give the graph, and it will give whether it is a positive or negative. So these are the two methods which have become very common for detection of the growth as well as for anti tuberculosis drug susceptibility testing. Then line probe assay, it is a probe based detection of amplified DNA in the specimen. So use of line probe assay in TB diagnostic, identification and speciation of Mycobacterium tuberculosis can be done, and it also detects non-tuberculous mycobacteria. And it also detects the resistance to anti-tubercular drugs, first and second line drugs. The anti-tubercular drug susceptibility can also be achieved. Especially line probe assay is useful in particularly in the INH monoresistant cases of tuberculosis, which are not diagnosed by gene expert. The limitation, it can be performed only in the positive cultures or smear positive clinical specimens. So this is the principle of line probe assay. The specimen is taken in the closed tubes, falcon tubes, and the DNA extraction is done. And the DNA, this is a particular target is amplified by PCR. Amplification is occurring by PCR. Then further, the hybridization with the help of probes. So particular probes, the probes may be for detection of the organism or for detection of the various species, and also the probes also can be device for detection of various drug resistance genes. So after by binding of the probe, if that particular gene is there in that amplified product, the probe will get bind along with the enzyme alkaline phosphatase. Then after addition of the substrate, then there is a development of the bands, and we have to evaluate the steps of evaluation where the genotype of the organism can be detected. So line probe assay is an advanced method where all the things, identification of various species, then genotype as well as the drug resistance can be detected. So it is done in the BSL-3 lab. So then next, the recent method is detection of lipoarabinomannan, and it has been permitted by WHO also. So what is lipoarabinomannan? It is a glycolipid present in the cell wall of mycobacteria. So it is a point of care testing. Lateral flow urine sample is taken, and in that we are detecting lipoarabinomannan. So lateral flow lipoarabinomannan, abbreviated as LFLAM. So which can be point of care testing, and it detects the active tuberculosis cases, especially the people with HIV, especially those with severe HIV disease, or those along with that low CD4 count if it is less than 100 microliter. So it is just like a card test. We have to charge the specimen. So there is a formation of control band, and then there is a formation of this sample band. So the formation of the bands. So lipoarabinomannan. So as per the recommendation of WHO, it is done in the HIV patients and those severe HIV disease with CD4 count less than 100 per microliter. Adenosine deaminase, another method, adenosine deaminase detection. What is adenosine deaminase? Deaminase is the enzyme involved in purine metabolism, and there are so many research articles which have shown that it can be used as for the diagnosis of pleural effusions because of the tuberculosis. So the values above 40 units per liter, it is confirming the tuberculous pleural effusions. The tuberculin test, all of you know, the tuberculin test is a delayed hypersensitivity reaction where 5 tuberculin units it is injected in the forearm intradermally. Intradermally, where there is a formation of bleb like this. Formation of bleb indicates the successful injection. It should not go subcutaneously. And the patient is advised to come after 48 hours. We have to measure. If there is a erythema and induration more than 10 millimeter, it indicates positive. So tuberculin test rather than diagnosis, it is a non-specific test which will give the whether there is a delayed hypersensitivity towards the tuberculoprotein. So the interpretation should be done in caution with caution because the just exposure to the tuberculoprotein may give tuberculin test positive. Even the persons who are immunized with the BCG, they can also give the tuberculin test as a positive. So therefore, always we should keep in mind that we have to interpret the test along with the clinical data and some other supplementary tests. Now come to the sensitivity testing. So why it is becoming important, because there are so many incidences where the multi-drug resistant tuberculosis are there, XDR, XDR tuberculosis cases are there. So these are the various method, resistance ratio method. In this, MIC of the test strain simultaneously is compared with the MIC of the standard strain, and if it is 1 or 2, it is a sensitive. If it is a 4, it is doubtfully resistant. It should be again repeated, and if it is 8, resistant, and such report should be released. Then absolute concentration method, in which MIC is detected of that test strain, but it is not compared. So it is as compared to the resistance ratio, it is a substandard. Then proportion method, if resistant, if 1% of bacteria grow in presence of the drug. Then the automated methods, backtake radiometric methods, MJIT 960, this can also be used for detection of the drug resistance against the anti-tuberculous drugs. So animal inoculation for diagnosis of tuberculosis. Now it is a history. It has become obsolete because of various reasons. It is not better than culture. Culture is simpler and safer and cheaper. So animal inoculation means we have to maintain the animals and animal house, which is very costly. Purchasing the animals is also costly. It is against the animal ethics guidelines. It is time consuming. Once the animal is inoculated, we have to wait for 4 to 6 weeks. And excretion of the organism, excretion of Mycobacterium tuberculosis creates health hazard to the laboratory workers. Mycobacterium tuberculosis is highly pathogenic for guinea pigs, but not pathogenic for rabbit, while Mycobacterium bovis is pathogenic for both rabbits as well as guinea pigs. So at that time, the inoculation of the animals was used for differentiation of Mycobacterium tuberculosis and Mycobacterium bovis. So this is the algorithm used for the diagnosis of tuberculosis. So various tests are available. So we have to follow this algorithm. So people living with HIV/AIDS, pediatric population, extrapulmonary tuberculosis, presumptive drug-resistant tuberculosis, directly we have to go for CBNAT. That is a cartridge-based nucleic acid amplification test, and we have to interpret it further. If MTB is detected, if it is rifampicin sensitive, we can go for we can label it as a microbiologically confirmed case of tuberculosis. If MTB is detected and rifampicin is interpreted, repeat CBNAT on second sample. If it is indeterminate on second sample, collect fresh sample for liquid culture and lime probe assay. If it is rifampicin resistant, refer to the management of rifampicin resistance. Then come to the presumptive TB patient. Apart from these three, so smear examination. If you pick up the case, smear regardless of chest X-ray, again it will be the microbiologically confirmed tuberculosis. If smear is negative and chest X-ray of suggestive of tuberculosis, we have to go for CBNAT. Again, CBNAT Mycobacterium is detected. Again, we have to go for the these three: rifampicin sensitive, rifampicin intermediate, rifampicin resistant. Then if mycobacterium is not detected in CBNet, the result is not available. Then we have to, depending upon the clinical suspicion, it can be diagnosed clinically. If it is clinically not suspicion is not there, considered alternate diagnosis. Then another is the chest X-ray. Here, smear and chest X-ray either negative or not available with high clinical suspicion. We have to go for CBNet, and again the same algorithm should be followed. So this is about the laboratory diagnosis of tuberculosis. So a range of options are available. So in concluding remarks, what I would like to say, range of options are available. So we have to follow the algorithm, starting with the age-old established methods like direct smear microscopy or culture. If automated cultures are available, we can utilize the automated methods. We have to use the molecular methods, in which gene expert is very, very helpful. Within the 2 hours, the report will be ready. Then they can be also coupled with the non-specific immunological methods. So we have to choose it widely and apply the algorithm. And so in total take-home messages, use the combination of the tests for the uh, successful treatment of the patient, successful diagnosis as well as treatment of the patients. Thank you for your patient listening. Thank you.